minds. And we are so happy to have you with us today, Dr. Harrison. I'm going to go ahead and stop sharing my screen and turn it over to you here.
Well, that's great. Thank you so much, Dalton. I think the opportunity to raise awareness about advances and new data is really important. And I'm always very pleased to accept an invitation from you, and I always like the discussion. So this time, as you know, I did prepare some slides because actually for me, it really helps if I can see a picture as well as hear somebody speaking. I'm relaxed on the slides being shared. That's absolutely fine. But they are quite sciencey, so forgive me for that. I'm pleased to see a couple of questions already coming in the chat. And I'll try to answer those too about MPNU and about interferon. But do keep your questions coming. I think it's absolutely great. I'm going to share these slides. They're slides actually I shared for patients in the UK quite recently, and maybe you might have seen them from some of our colleagues. So what I would say is on the subject of the embarrassing award, it was my great pleasure, but actually it's not really an award to me as an individual. It's an award to us, all of us. All of you here and Dalton and the other clinicians and scientists and pharma and patients who've been before you and their families who've all worked together to make progress happen in this field. We've got a long way to go, but we have made really good progress. And so it was a really exciting summer for MPN. And we're heading towards this kind of holy grail that I'm trying to show you on this slide about what would an ideal treatment look like. It would make everyone live longer, maybe without disease, but it would also be safe and tolerated with very few side effects. It would maintain healthy blood counts, reduce symptoms and risk of progression. But it would also be a reasonable cost so that not only those of us who live in affluent societies will be able to access it, but everyone be able to access it all over the world. It would be ideally a tablet. That would be great, wouldn't it? And it would selectively target the MPN cells, but not healthy cells. Is this completely Harrison pie in the sky like dream? Did I have too much coffee today? I don't think it is, but we're a little way off. So now I'm trying to get my slides to work. So this is a slide that I used at EHA, and I was trying to make the point to the audience who are mainly not MPN doctors that we've moved from this stage of Damashek, who first used this term MPN. So he coined the term myeloproliferative disorders then. This was in 1951. We've moved through kind of molecular revolution. We've got a therapeutic revolution, sort of, but we could do better. And now we're moving towards disease modification. So this is the journey we are all on together. And there was some, this is not an individual game. This is a team sport. I already mentioned that. These are some of the key team members. This is one of my slides actually, but I also had some nice pictures here. And there are some people that I haven't named here who I showed their pictures. But the specific things I'm going to talk to you a lot about today are a brand new target, mutation-targeted therapies. I won't speak about independent study because that's about luspatercept, but I can answer questions on that. A study with Selinexor, and then for those of you who are listening who've got ET or PV or have got questions about allele burden and other things, I'm going to talk about that. And on MPNU, it's very hard for us to include MPNU patients in studies, but we really need to move towards a better classification of disease and better studies that don't leave anyone out. And that's in our mind too. So I think this audience is pretty expert. You know that we don't include CML as an MPN anymore, but our main MPNs are PV, PMF, and ET, and MPNU, or not otherwise specified, sits in the middle here, but the mutations are the same. JAK2 is the most common one here in blue, then calreticulin for ET and PMF, and MPNU patients, small numbers of patients with MPL, and small numbers of patients that lack a driver mutation. And for you, if you have no driver mutation and ET, what we're currently discussing in the field is, should we actually do less treatment for you? Because you're less likely to have complications. But these are things that we're sort of working out. So the obvious mutant targeted therapy that we've been looking at and talking about for a little while now is CALR. So a therapy, generally an antibody that targets CALR. And mutant CALR comes out of, this is the cell, it comes out of the cell and it binds to a receptor or a socket on the outside of the cell. Normal CALR doesn't do that. So mutant CALR is waggling around outside the cell saying potentially, hello, I'm here, come get me. And that's only on the outside of cells that have got the mutation. So it's what we call a rare example of a tumor cell specific protein. So it's a unique opportunity. And it's one that we've been looking at for a little while, and we've got several different ways of attacking it. One with vaccination, that generally hasn't worked. Many patients that have a CALR mutation have their own antibodies, and augmenting them by vaccinating patients hasn't generally worked. So far, we've only got data with this monoclonal antibody that binds to the mutant CALR and stops it from making the cell divide more. But there are other agents that bind the mutant CALR and bring a T cell. Remember T cells from the pandemic? Agents that bind the CALR and bring a poison, these red starred things here. I'm going to talk to you a bit about that. And then CAR T, those of you who watch the cancer story generally may have heard about CAR T cells. They're coming for MPN, right? We can make a CAR T cell. There are 2 of them in development that recognize CALR. JAK2 and MPL are not expressed on the outside of the cell, so these are only really things that are going to be targeting CALR. So far, we've seen data, but we've only seen it with this drug, Inca 033989. So new it doesn't have a name still, but not so new that we don't know a lot about it. So we've been treating ET patients now, about 114 of them, out to more than 18 months. The patient's platelet count drops very quickly. The 3 different colours are 3 different doses. These are patients with one type of CALR mutation, which is the commonest type, and then patients that don't have this type 1 mutation. They have the same responses, but they generally need this higher dose, 1,500 or 2,500 milligrams. So these responses are rapid. This is much faster than we would see with hydroxyurea or interferon, way faster. And they're durable. And 70% of patients got complete response. So they got platelets less than 400, normal white count, normal hemoglobin. And overall, 87% of them achieved either this complete response or nearly a complete response. And these were patients who had already failed on other therapies. So this looks really exciting. It's really well tolerated, but it is given as a drip, and it's generally given every 2 weeks. We also have seen reductions in the amount of mutant cells. Some patients very dramatic, much more dramatic than we've seen with other therapies, but we do see this with interferon, and we do see this with Jakafi or ruxolitinib. Not all patients have these good responses, and we're trying to work out why not. The other group of patients we've been trying this out with are myelofibrosis patients. And there's a different groups of patients that we've been looking at. So just focus here on the right-hand side first. These are patients who've already failed a JAK inhibitor like ruxolitinib, momelotinib, fedratinib, pacritinib. And in green are the patients who haven't had a JAK inhibitor because they're so-called ineligible. So this really helps us to work out that regardless of if you've already failed a JAK inhibitor or not, you're probably going to get a good spleen response. And the asterisks are those patients that don't have a type 1 mutation. So that's spleen, symptoms. This is spleen. And they really made me struggle making this presentation. They gave me so many different colours, right? But this is where I think it's really helpful for you to see what we're looking at. Each individual bar here is a patient. Each of these bars show how the patient's spleen has changed from the baseline here on this axis, and whether it's gone down, which it has for most patients, or whether it's gone up, which it has for some patients. And here blue means these patients have got extra mutations. But what we can see is what we've regarded as the gold star, which is 35% reduction in spleen volume, roughly half of the palpable spleen. That was achieved by nearly 40% of patients overall. That is as good as ruxolitinib in newly diagnosed patients. So super exciting. Going to speed up a bit now. What does hemoglobin do with ruxolitinib? Generally, it goes down. But here we saw that for patients who were anemic or not anemic at the beginning, the hemoglobins were going up. In blue are the patients who've had a JAK inhibitor, and in green are the patients who've never had a JAK inhibitor. So it's going up for everyone. Why is it going up? Well, it's probably going up because normal blood production is coming back. We also saw a reduction in circulating blasts or immature cells. This is something we see in almost all patients with myelofibrosis. So it's really changing the basic biology of the disease. And here we see, I think I might have shown you this before or spoken about it. This is what a bone marrow for a patient with myelofibrosis looks like. In yellow are the megakaryocytes or platelet-making cells. This is how we recognize a patient has myelofibrosis. These are increased in number, close together, and there's fiber tissue in the background. You can't see it on this stone. So this is at the first biopsy before we treated a patient. This is after the patient's had 12 infusions. The number of blue cells has gone down, yellow cells has gone down, and they're not so big anymore, and they're not all hugging and kissing each other. They're kind of separated, right? That's normal. And also there are these blue cells which don't have the mutated CALR on their surface. Also in the bone marrow, in line with the hemoglobin going up, we saw increases in red cell precursors. So we don't see this with other therapies, except if we do a bone marrow transplant. So this is super exciting. And this is disease modification, like the journey I was telling you about before. So we need to see what more can we do with this? Can we get better with this? We'll expect to see this at ASH, and Dalton, if you invite me back, I'll tell you what's happening to patients that get these treatments at ASH. These two we haven't seen yet, but here's the but. Giving an antibody is one thing, but giving an antibody that brings a T cell, you're more likely to get complications. So CRS means cytokine release syndrome. So that can be mild, like a fever or a headache, but it can also be quite serious. So we keep these patients in hospital. And we are currently treating patients with this kind of antibody all over the world, and we'll be sharing the results soon. So less toxic, but maybe less effective. But I think what I showed you with this simple antibody, which will soon be given as an injection like interferon under the skin, is very exciting. What about all the rest of you with other mutations? Well, we have got the next generation of JAK inhibitors coming. So our current JAK inhibitors act in a so-called type 1 fashion, right? So they bind the active conformation of the receptor. Here's a membrane or the outside of a cell again. Here's a receptor. Here is JAK2 bound to the receptor. And mutated JAK2 here with a little yellow blob on it. So it makes the receptor bind together and signal. And these are current inhibitors block this in its active conformation, and so you can get escape. There are now new drugs, this one, another one from Insight, another one with letters and numbers, binds to the pseudokinase domain where the mutation is in JAK2 and has been shown to be selective. This is what this shows. This is wild type, normal JAK2, and this is inhibition of activity. So it's more, you get more inhibition with the V617F. This is in clinical trials at the moment. It's a tablet. And what was presented at EHA and at ASCO was Ajax Therapeutics. So this is a different type of JAK inhibitor. It's type 2. It stabilizes this domain in its inactive state, and it's supposed to be more potent. And it's so exciting that a big pharma company has gobbled up and purchased Ajax for several $1 billion because they're so excited by the results. Well, what do the results look like? So first of all, this is this molecule. This is how we describe the actions of a molecule. The little red blobs are which kinases or enzymes they inhibit. Some drugs like ruxolitinib would have loads of red blobs in. That can be a good thing. That can also be a bad thing. What we see here is what ruxolitinib does to normal cells, so it reduces their ability to divide. And then when we make them resistant to ruxolitinib in the test tube, which we do by just giving them loads of ruxolitinib, which is what we give to our patients, but you can see that it doesn't work as well. When we give these cells, either ones that have never seen ruxolitinib or the ones that we've been feeding ruxolitinib for ages, this drug, AJ11095, we see reduction. So in the test tube, it appears to work well. In the patients, wow, look at these spleen reductions. So this is 35% spleen reduction, 76% of patients. You can effectively ignore the little, the different colors. They just mean different doses. When we first start testing the drug, we test it at different doses. And the stars mean patients that developed the response a little bit later. So this is really striking, but I want to just be cautious because there are only 23 patients, but it's very, very exciting. The room was packed to hear this being presented. What do we also want? Yes, we want few side effects, and the side effects of this drug are pretty similar to ruxolitinib, some signal of altered taste. But we also want to see change in the mutated cells, and we don't see that very much with ruxolitinib. It can take 2 or 3 years, even in patients with PV. But look here, we're seeing patients with 50 or even 20% reduction. And overall, of the patients who had samples taken, 21 out of 22 of them had a reduction. And although we don't routinely check this out in clinical practice, it's probably really important. Many of you probably wondering, should I get my VAF checked? VAF means the percentage of your gene that's mutated. We wouldn't change your treatment on that basis, but I kind of try to do this for my patients on a once-a-year basis. It's not always easy for me to get it done, so don't get too upset if you can't get it done, but maybe get it done once in a while if you possibly can. Now, we've spoken about CALR targeted therapies and Dalton, we've spoken about JAK2 targeted therapies. What about all of you who don't have one of those mutations? Like you've got a MPL mutation, or maybe you're triple negative, or maybe you think, well, surely there must be more than this. There is Alethio Therapeutics, which is a spin out from Oxford University in the UK, led by Adam Mead and Beth Sala, who are both MPN experts and great colleagues of mine. And they've developed this thing, or found this marker called G6B. It sticks out of the megakaryocytes, which are the platelet-making cells. And it's thought to stop the platelets getting active. It's only expressed in blood-forming tissues, but especially on platelets. If you get rid of that gene, it causes low levels of platelets in mice. But in MPNs, you guys have a lot of this on the outside of your cells, way more than somebody who doesn't have an MPN. And it doesn't matter what mutation you have. You have a lot more of it waggling around on the outside of your cells. So what are we doing about that? So, well, first of all, here's the data that shows what's different. So this is something that Adam and Beth did in their patients in Oxford, and they showed that MF patients with a JAK2 or a CALR, but also MPL and other mutations, have increased amounts of this protein on their cells compared to normals. So it is expressed to excess in mutated bone marrow tissue. And so they've made an antibody, a bit like the CALR antibody that we were discussing earlier, that can recognize this. And we're going to be testing it in patients with ET soon. And then those of you who were joined earlier, I spoke about this thing called an ADC, or a drug conjugate, or a toxin with little red stars attached to an antibody. So they're going to make this antibody more potent by putting a toxin or a poison on it. So when it comes into the bone marrow and it binds the cells that express this, it will make them die. So it's targeting MPN cells. So I think this is super exciting, and it's sitting in the hands of MPN experts. So that's all I've got to say on targeted therapies. Dalton, if it's okay, I want to move on and talk about some stuff for MF patients now and PV and ET patients now. Is that okay?
Absolutely, go ahead.
So for those of you who've got myelofibrosis, you'll know that we've been looking to try to get ruxolitinib better, or better results with ruxolitinib, longer lasting results, or more patients to get responses. And it was ironic for me because at EHA, it was 15 years, 15, since I presented the results with ruxolitinib. So I was able to stand up and show this data, which is with Selinexor. I'll tell you what Selinexor does in a minute, plus ruxolitinib for patients with myelofibrosis. And so this has generated a lot of excitement. And the key takeaways here, and if you want to read an academic paper, it's quite readable. You can scan the little QR code here on the slide, and it will take you to a free article for those of you who like reading articles. We saw better spleen responses. We saw similar symptom responses, but we saw in 6 months a survival benefit. We saw also higher rates of reduction of mutant gene-bearing cells, and a predictable safety profile, which is a bit different from Selinexor, so we need to talk about that. So what is Selinexor? Selinexor inhibits XPO1. And XPO1 has a role in, here it is, here it is, here it is. 4 key things that are relevant for you guys. 1, it affects JAK-STAT signaling. 2, it slows down division of cells. 3, it inhibits inflammation by affecting this thing called NF-kappa B. And 4, it makes cells die by this process called apoptosis, or which is cell death. It's a process that all of us have going on in our body all the time. The other important thing about Selinexor is it's already been given to about 40,000 people in the world, because it's used for myeloma and it's been tested in other blood cancers too. So we know quite a lot about dose, and we know quite a lot about safety. So here is the spleen reduction. In blue is Selinexor, in orange are the patients that just got ruxolitinib and a sugar pill. So you can see that more patients got a reduction in their spleen, and it reduced by a greater amount. And you can, for those of you who like numbers, these are the percentages. So about 50% of patients, whereas the ruxolitinib patients were a bit behind. And this is a test that we use for significance. So P, if it's less than 0.05, is significant. We've seen that with all the combinations that we've used, basically. So what's so exciting about this? First of all, if we look at all the different types of patients, how old they are, whether they're a man or a woman, what their race is, where they come from, what type of myelofibrosis, is it primary, is it secondary, what's their mutation, etc., etc. For most of them, there was more spleen reduction with Selinexor. This is the kind of analysis we do. So anything this side here favours Selinexor, anything here favours ruxolitinib. Some of them are really sitting bang in the middle, so whether they've got high-risk disease or not, for example. And here's the data for survival. So this is what's called a Kaplan-Meier plot. And here are the Selinexor treated patients. Don't look so much at this bit, because we don't have them. This down here is how many patients we've got this far out on the study. So here we can't really say anything confidently, but by here, this is statistically significant. It's less than 0.05. This is exciting for us because we didn't show this with ruxolitinib for 15 months or 20 months. But it is very early, so we need to be sure that we're definitely seeing it before everyone that's just on ruxolitinib wants to run out and get Selinexor as well. So hats off to these patients. They're staying on the study, and we're going to keep following this up and make sure this does stay separate. Interestingly, whether the patients had a spleen response or not, regardless of what treatment they got, predicted overall survival. So 98% of patients that got 35% reduction were alive, compared to 88%, and this is at week 72. We did know that already with ruxolitinib. So what we think is happening here is by getting a faster and deeper spleen reduction, we're actually changing the disease a bit. But as I said, it's early days. About a third of patients had a 20% reduction in the mutant gene versus about a quarter with ruxolitinib. And broadly, this correlated with spleen reduction. I spoke about blasts, and I showed you the data for blast reduction with Inca. This is the blast reduction for patients treated with Selinexor. And this are the patients treated with ruxolitinib. We expect to see some blasts in the blood of patients with myelofibrosis. It doesn't mean they've got leukemia, it just means that they're putting out immature cells. And then this is the kind of topsy-turvy thing, like how many patients had, of the patients that had 0 blasts, so they're not here, because these are the patients that had blasts. Of the patients that had 0, how many of them did blasts appear? And you can see, again, it's less for Selinexor. A soft indication, something that we don't routinely do to evaluate a drug, but your doctors will be doing this when you see them in clinic. But Claire, how well do people tolerate it? So the myeloma doctors said to me, Selinexor is a really difficult drug to give my patients. They feel sick. They feel really tired. And I know that MPN patients have fatigue as like the #1 problem, right? So is this a problem? And I just want to orientate you for this. Everything in blue here is Selinexor. Everything in orange is just ruxolitinib on its own. And these are individual side effects. Darker colours mean that the side effect was worse, or so-called grade 3, 4. So you can see, for example, we saw much more thrombocytopenia. That means low platelets with the Selinexor combination, and it was a higher grade. Even though the patients were taking 2 anti-sickness medications when they took the Selinexor, which was only 1 day a week, we still saw more feeling sick in the Selinexor patients, but only 3 discontinuations occurred for this reason. So only 3 patients stopped the drug. We also saw more fatigue and only 1 patient stopped because of that. There were no differences in leukemia. We put this here because we did see a slight uptick in leukemia with pelabresib, which was our most recent combination partner. So I saw somebody asking about navtemadlin in the chat. So navtemadlin is a drug that is being tested in a similar trial. Navtemadlin works in a similar way to Selinexor. It works on cell death. And in that study, which we don't have the results for yet, Marty, you asked about that. In that study, everyone's getting ruxolitinib. And then if you haven't had a good response to ruxolitinib, you basically get randomized to either get navtemadlin or a sugar pill, but you continue with your ruxolitinib. I would encourage you to consider going on a clinical trial. There's lots of evidence that patients who are on clinical trials do better. But of course, you're giving up extra time and you're giving up time that you're not going to get back. And maybe it's going to cost you more money to get to the hospital, and not all trials reimburse costs. But I think HealthTree's probably got information about being on a clinical trial. Is that right, Dalton? Yeah, you're nodding.
Yes, we
Many
have. Sorry, I was just going to let everyone know we do have information about clinical trials. We also have a clinical trial finder. So if you do connect your medical records, we can match you with potential trials that you could be eligible for. Because going through clinicaltrials.org or .gov can be kind of a bear. There's a lot of information in them. So we try to take some of that legwork out. So if anyone is interested, please feel free to reach out to me, and I'd love to help you find a potential trial for you.
Yeah, I don't recognise ClinTrials. I recommend ClinTrials.gov. It's like super confusing. And also it doesn't always give you what studies open, right? So that's a great service that HealthTree offer patients. I saw a question about might there be a trial for patients with a rare MPL mutation? That came from Martha and your iPad. So Martha, I think that the Alethio drug G6B is probably a good one for you, but there is also a targeted therapy from Insight specifically for patients with MPL mutation. I can't tell you any more about it because it's like tip-top secret, but it's coming to a site near you. And so hats off to Insight and all these companies. They're not forgetting about, the 5 or 10% of patients that have these more unusual mutations. Okay. Shall we move on? Is it too much science or is it okay?
I love
It's
the
okay?
science, and our audience, I think, does as well.
Okay, all right. So I haven't forgotten you patients with ET and PV, all right? And I saw the question about interferon and how do we use it, and I'm going to try to talk a bit about that. And this is a beautiful slide that came from a lovely, lovely investigator from Italy called Francesca Palandri. If you have the opportunity to hear her speak, listen to her speak. She's amazing. And she collects loads of data about her patients in Northern Italy and gives us loads of really good insights. So for ET patients, there are studies with the CALR drugs that we spoke about. So Inca. Plus, there are 2 other antibodies coming. Insight has another antibody, Demora Therapeutics, and also Calatrix Bio. They have antibodies coming, and they're probably going to be injected under the skin like interferon and longer half-life. For ET patients, there's also a bomedemstat, which is the LSD1 inhibitor. Expect to see some results later this year or early next year with that drug for patients with ET. And this is the drug for you, Martha, for MPL. It blocks MPL, which is TPOR, the thrombopoietin receptor. So look out for that. Get Dalton to match you up with a centre when that's open. But also this drug can work for everyone with ET. For polycythemia vera patients, that a lot of the focus at the moment is on these drugs that target the iron pathway and reduce the need for venesection or phlebotomy. I'm going to tell you a bit about some studies with that. But we're also looking at BET inhibitors and epigenetics, and this drug, the LSD1 inhibitor, they're looking at opening another study in PV. And then all of the newer JAK inhibitors I spoke to you about, they're all going to be tested in PV, and some of them will be tested in ET as well. So iron metabolism, this is a really complicated slide, and iron metabolism is really complicated. But all you really need to know is what we're trying to do in PV is stop the iron getting to your bone marrow, but allowing it to get everywhere else in your body. So when we do phlebotomies on you, you get iron deficient and you get tired and your nails get brittle and your hair gets thin and your skin's not so good. And you get itching more as well. So we're using all of these different drugs to try to block iron getting to your bone marrow. And to try to reduce the need for phlebotomy. They won't affect the other blood cells, they won't affect your allele burden, but they'll reduce the burden of phlebotomy. And we know that's not great. You have to be in hospital for an hour or so to have it done, and it's not perfect. So there were lots of different studies looking at this. No difference in thrombosis, so there was not likely to be an increase in thrombosis. That's really important. This is a novel agent targeting TMPRSS6. This is another agent looking at reducing phlebotomy. But I think the top line here is there is likely to be a drug that reduces the need for phlebotomy if you need a lot of them. And needing a lot of phlebotomy means your disease is not well controlled, and it means that you're getting iron deficient and probably needing to be in hospital quite a lot. The one that is most far advanced in development is rusfertide, and this may be approved by the FDA. I think this is probably largely an American audience, may well be approved by the FDA later this year. Now, question on interferon. I saw some news about approval of a new formulation of Besremi this week by the FDA. And there's a question from you, Jane, about patients on low-dose interferon. Will the treatment continue indefinitely? So the studies that we saw at EHA were mainly about ET patients. I know you're going to groan because you asked a question about MPN unclassifiable. But if your MPN unclassifiable means that your platelet count's high, probably quite like an ET patient. In this study, which was a randomized study comparing interferon to anagrelide, it was shown that interferon was better and that more patients got better control of their blood count and that there were no new side effects. And again, there was this study, which was a safety profile study. So for me, I haven't shown a lot of detail on these because they told us pretty much what we already know. What I do for my interferon-treated patients, and I treat MPN unclassifiable patients with interferon as well, is I tend to start with a low dose, slowly ramp up to get a good control, and then keep patients on as low a dose as possible. And if you're doing well on it, yes, stay on it. Some colleagues stop interferon if a patient gets a really deep response, but there's not so much data on that. And then finally, I want to kind of come back to the beginning and what I spoke about at the beginning about, like, this is what I showed you today and the journey we've been on and that I've seen as somebody who's worked in this field now for like 25 years, is that this is all about teamwork. We need to work with you, we need to work with patient advocacy, like HealthTree, MPN Voice that we have in the UK and others, to understand what you need from your healthcare teams and what you need in research. And I'm just going to give you two examples of what we've done in the UK. And maybe Dalton can speak to what's been done through HealthTree and elsewhere. I also work with MPN Research Foundation, etc. And after this, actually, I've got a call with John Mascarenhas to look at some pooled data across the UK and US. So we asked you via MPN Voice, and some of you may be linked to this group. You get your information from wherever you like. And we asked a question, are you interested in allele burden and would you like to be part of a study about whether it matters or not? I'm quite surprised we haven't seen any questions on this so far. And do you want to help us understand a bit more what is the lived experience of having an MPN? And so what the MPN Voice team have done, and this is the MPN Voice team, it's all volunteers. And this is a slide that took me hours to make for EHA, so I'm using it as much as I can. And maybe some of you also linked in and voted on this. So we asked, will you be part of a study looking at does allele burden matter? How amazing are you as a community? We got 1,000 responses in 24 hours, which really helped us to go to a grant award funding body in the UK and put this study together, which is called AmbiMPN. And so what we'll be doing in this study is a bit better illustrated in this nice picture here. I think a picture is better than loads of words. So we're going to be taking groups of patients and we're going to be recruiting them and taking samples every year and measuring their allele burden and asking what's happened to you? Have you had a blood clot? Has your disease changed? But it could take us a really long time to show this, but we're going to make it go faster by, if you ever have a genetic test in the UK, by the way, we store your sample. We never throw it away. So we've got the old samples in general. We're not perfect, but generally we don't throw it away. So we've got the old samples up to 15 years back. So we can really power up and get to like 24, 25 years much faster. So this is AmbiMPN. Loads of you responded to a questionnaire about this, and some of you will be involved in helping us to deliver this study. It's primarily going to be in the UK, but we're going to work with colleagues across the United States and in Europe. And then we asked about lived experience of, and so we've been working with a tech provider that links this thing, which is a Withings watch, which tells me that I haven't walked enough steps yet today. I generally try to do 12,000. And it links in and tells me how much I slept, what my heart rate variation was. And then MPN patients in the UK are also putting in their symptom score. And using this, we've been able to collect almost 3 million data points. And what we showed at EHA was actually fatigue correlates better with steps taken and with hemoglobin because we can pull in the health record. So it will help us then to be able to measure better what your lived experience is, but also what happens when we give you a new treatment. So I think that's a super duper example of the community working together. And this just shows you a little readout from the app. So I think you've had like 45 minutes of my voice, which is like way too much. So I'm going to stop here and have a little Q&A. I'm loving that you put questions in the chat. No question is a silly question. Let's get a conversation going. What do you think, Dalton?
Wonderful. And thank you again, Dr. Harrison. This was amazing. Just getting to see all the work that's being done, both the targeted therapies, really excited about the SENTRY trial updates. I actually did a podcast with Dr. Mascarenhas when they're starting to enroll for SENTRY. So
Yes.
very exciting to get the updates and see how far everything's coming. And then the patient reported data and getting everyone involved. That is so incredibly important. The work that MPN Voice is doing, MPN Research Foundation. Here at HealthTree, we have a survey that we're running that is about lived experience of fatigue for MPN patients that I highly encourage any patients who are on here
Oh,
to take part
I want
in.
to see that. Great.
Yes. Mascarenhas, so Dr. John Mascarenhas helped us develop it. So I'm happy to go over it with you. It is a wonderful survey, and just getting the community connected and involved it makes such a big difference. So thank you again for this. And as Dr. Harrison said, we have a little bit of time for questions here. So please feel free to drop any of those questions in that you may have. But one that in conversations I've had with patients was, how do you think AI is going to impact the landscape of MPN treatment and research going forward? AI, I feel like, is kind of a hot topic everywhere. And I've had multiple patients bring it up in conversations of, is AI being implemented in anything for MPN patients right now?
Yeah, great one. So yeah, we're using AI actually in the app because you can't analyze
Mhm.
2.7 million data points without using something like that. We also are using AI to analyze bone marrow biopsies. I know patients always wince when we talk about bone marrow biopsies, but I showed you the biopsies and the blue and the pink, blue and the yellow megakaryocytes. We're using AI to analyze those marrows to see what really are the changes because currently we use a human being to look down the microscope and make a judgment. And humans are lovely, but we're not all perfect. None of us are perfect, in fact. So that's where we're using sort of AI at the moment. But understand that Ajax will have used AI to develop find which was the best molecule. It's everywhere really, and we also use it to help us be quicker in clinical practice, so we can spend more time with patients and less time on admin. I'd love to do that. I think
And
the other thing about AI is, and on the subject of surveys, etc., is it is really important that you understand that when we use data from you, we're using it in an anonymized way. And if you're responding to a survey, you should always check that out.
yes, and that is very important for people to know, that the data is anonymized. So we're not saying that John Smith has XYZ and this is how I filled out his survey. It's anonymized, and it's really just helping get that larger picture of, okay, how are MPN patients as a whole being affected by this? So it's anonymized. It's a great way to get involved in that research process. And um, Dr. Harrison, you were an expert in MPNs, and to hear that you have so much involvement with surveys, I think really does add validity that the experts are paying attention to these surveys, and those surveys do have an impact.
Well, we don't have an MPN. We don't know
No.
what it's like, right? We also don't necessarily know what your priority is. Understanding that, what do I see that these CALR therapies might deliver? And I see a few questions about that in the chat, Dalton, as well. Is it possible that so Lisa, you asked about type 1 and type 2. I think they're responding pretty much the same, but we just need a bigger dose. But there are newer antibodies coming that might work a bit better for type 2. It's a slightly different shape molecule, and the way that an antibody works is a bit like a key and a lock. So the key doesn't fit quite so well depending on the type of mutation that you have. But what I think that these therapies might do is, and I was talking to a patient about this just yesterday in my clinic, set the clock back. So set it back to, if you've got MF2 before you developed ET, but you might still have a mutation. So we need to know from you guys, is that okay? Because eradicating it might bring more problems. So these are things that we really need to learn and understand. And is it okay
Very.
that Selinexor causes these side effects? Is that acceptable to you if you get a bit of survival benefit? Living well is very important too, I think.
Yeah, and I think something else that comes along with that, of now with the Selinexor, and I know that data's earlier on, and nothing is 100% conclusive as of yet, but the excitement of talking about therapies that really are adding survival benefit. Whereas a long time I know these MPN therapies was really evaluating more spleen reduction or symptom reduction. So having that shift where survival benefit is really being evaluated potentially, I think is incredibly exciting to see how far things have progressed. But it does open up another conversation of, are patients okay with dealing with some perhaps more difficult side effects in exchange for that survival benefit? And that's not something that the field has had. The field hasn't had been in a place to have those conversations until very recently. So it's exciting, and it's important that patients share their feedback and share, so that the experts, as you said, you're not the ones living with MPNs, but you are the ones getting the feedback and taking that feedback and having that impact the work that you're doing. So for any of the patients out there, I just highly recommend to get involved, either through surveys or if you're interested in clinical trials, but be a part of it, because truly patients are the most valuable part of all of this. This is why this work is being done, is for the patients, and your patient voice matters. I think we are out of time here, so I'm gonna reshare just as we close up. But I wanted to thank you again, Dr. Harrison. Truly, this was, as always, just so, so amazing having the chance to work with you and to hear from you. Um, you said it during, but I will absolutely take you up on ASH. So I'll be in contact with you about that. Any opportunity I have to work with you, truly, I'm so honored to have the ability to work with you, and to have you share with our audience, I think is just such a gift. So thank you for everything that you do, and for your
You're welcome.
generosity.
Thank
So
you, and thank you to everyone at HealthTree. It's always great to have a conversation with you. It would be useful to know whether people think slides is better than a conversation. I personally like the pictures, but useful to
I
know
am a
that.
sucker for the pictures too. So, but I'll
Okay.
let you know if I get feedback about it.
All right. I'm going back to the hot UK now and hoping that we continue to do well in the football. Take
Excellent.
care, everyone. Bye.
Bye, Dr. Harrison. And as we're wrapping up here, I wanted to let everyone know that we do have a Black health community here at HealthTree. So if you or someone you know could benefit from this, please feel free to reach out to me, and I'm more than happy to get you connected with Valerie. She runs this program and she's incredible. So if that's of interest to you, just let me know and I will make that connection for you. And we do have some upcoming events that I wanted to share. So on tomorrow, July 9th, we have a MPN community gather. So if you would like to get together with some other MPN patients virtually, and just share your experiences and have a conversation with people who truly understand what it's like to live with an MPN, this is a fantastic space to do that. And then on Wednesday or Thursday, July 20, or that should say the 16th. But it's what to ask your physician after a diagnosis. And then on July 8th, we have a community gather for caregivers. So if you are a caregiver yourself or you have a caregiver that could benefit from speaking with other caregivers, I highly recommend checking that out. And finally, just again, another thank you to everyone in our audience for joining us today. Please feel free to reach out to me if you have any questions. We do have a quick survey that you can fill out as we're hopping off here. If you take a moment to fill that out, I do really appreciate it. You can just leave some feedback about things you liked, things that you'd like to see changed, or suggestions for future topics. So I do personally read all of those. So please take a moment to fill that out. It is greatly appreciated. And I hope everyone has a fantastic rest of their day.